Hi, I'm Jack Cush with RheumNow, reporting from EULAR 2023. I want to talk about a synthesis of preclinical RA data that's come in. As you've heard at this meeting, there was a presentation on the APIPRA study. This was a preclinical RA intervention in over 200 patients who were patients with arthralgia and ACPA positivity, no swollen joints. No other risk factors for development other than the ACPA positivity and arthralgias. Patients were treated with 1 year of placebo or abatacept, shown at that point that 6% on abatacept and 30% on placebo developed RA at 12 months. In the next 12 months, everybody was on placebo or actually taking nothing. And while there was some catch up in those that were on abatacept initially and then were on nothing, they never really did catch up. So there was a delay in the onset of disease. And the question is, how does this stand in comparison to other diseases? Let's do some accounting here. There have been a number of trials. There were two fairly big trials on methotrexate, and then several others actually that also failed. The PROMPT was a 110 patient trial in undifferentiated arthritis showing methotrexate didn't work. Treat earlier, 236 patients who had to have inflammation by MR and not necessarily be ACPA positive, who got methotrexate and showed it didn't work as far as developing RA. STOP RA were patients who are ACPA positive and arthralgias only, and then 142 patients who either got placebo or hydroxychloroquine. Hydroxychloroquine didn't work. And then STAPRA, a 62 patient trial who received statins, showed it didn't work. So methotrexate, hydroxychloroquine, statins. PRAIRIE was an 81 patient single infusion of rituximab that looked like it worked at 12 months, but did not work at 30 months. So some say maybe positive or delay, some say a negative trial. And then we're left with three abatacept trials that in fact were positive. And one, the ADJUST trial, 55 patients, published by Paul Emery in 2010. The ARIA study, published in the last 2 years, presented at ACR, and EULAR, 98 patients showing abatacept prevented or delayed the onset. And the ADJUST trial from Emery showed it prevented the onset. And then recently, now this meeting, 206 patients treated with either placebo or abatacept shows abatacept at least delayed, if not prevented. So there's a positive, consistent signal for abatacept. But what you need to know is that the three trials, ARIA, APIPRA, and ADJUST, are actually in different patient populations. So let's begin with the mildest of them. And this is kind of akin to the STOP RA trial, and that would be the APIPRA trial. It's fairly mild. 2 or 3 tender joints, no swollen joints, very low SED rate, minimally elevated CRP, no other evidence of inflammation, and they're ACPA positive. And it shows a delay. Unless you look at patients who are strongly ACPA positive and strongly positive from multiple RA autoantibodies. If you have all 5 of them, it was preventative. But again, this is in a very mild population. It's a little bit different than in the ARIA study we talked about last year. Again, that was about 100 patients. You had to have MR-proven inflammation along with the arthralgia and the seropositivity. And that showed separation early on and out to 18 months. Looks like a delay in onset with the lines never quite meeting. So they had added degrees of inflammation as measured by MR inflammation in the hand or foot. And that's different than the Paul Emery ADJUST trial, a smaller trial, 55 patients, published 2010. But to get into that study, you had to have undifferentiated arthritis or up to 2 swollen joints. You could have 2 swollen joints, and actual synovitis, which is usually not allowed in these preclinical RA studies. But in that study, you got either placebo, 27 patients, or abatacept, 28 patients, something like that. And the abatacept patients had a lower rate of developing criteria-proven RA. The point is that with abatacept, at very mild, very moderate, or more inflammation closer to RA, seemed to have a benefit. So I think this is sort of clear cut. The question is, what is it going to take for you to actually use an aggressive therapy? And if you may want to use an aggressive therapy, sorry, Sarah, it's not going to work with hydroxychloroquine. Sorry, Susan, it's not going to work with methotrexate. And I don't know what to tell Sammy, who wants to use rituximab, because there's very little data and only one infusion. But the rest of you have to consider, if it's your mother or your mother-in-law, what are you going to do if they're seropositive, have arthralgias, and one more bit of inflammation? Would you use a biologic like abatacept? It's not currently an FDA indication or an EMA indication, but I think we're headed in this direction. And I think it's a very important question. Would you delay the onset if you could? Would you prevent the disease if you could? That's a no-brainer. But how long do you prevent it for? And if you do this early enough in the disease, do you change the long-term outcomes? It's kind of like CAR T-cell therapy in lupus. It's incredibly expensive. It's incredibly complicated. But if you give it to the worst possible patients, they all go into remission. Imagine if you gave it early on, would you not change the natural history of the disease? Maybe actually prevent the onset and onslaught of lupus over many years? Again, these are really thought-provoking, well-done clinical trials that in the end are going to inform your therapy, if not guide your therapy. That's it for EULAR 2023.